you. Thank you so much for having me. It's really an honor to speak today, and hope to give just a little bit of a brief overview of what we do as surgeons and kind of how we approach the patient that has aortic disease. Okay. So a couple of things that I wanted to cover today, and I know some of this has already been covered, but just a brief anatomy of the aorta, the types of disease that we primarily see, some of the options that we have for surgical repair, and what the recovery from surgery will look like. So the aorta is now getting recognition as its own organ. We used to think that this was just a tube of blood, this was just the biggest blood vessel in the body, but it's actually supposed to be treated in its entirety. And so we know now that what happens in one part of the aorta can eventually affect other parts as well. And so we look at this as a whole picture now. As surgeons, we focus on the thoracic aorta, which is contained in the chest primarily. Now, like a plant, the aorta starts from the root. Now, the root contains the valve, which is where it starts, but also the coronary arteries that provide blood flow to the heart. Following this, we have the ascending aorta, the arch, which is where the blood vessels branch off to supply the brain and the head, and then the descending aorta. And the descending aorta is usually what we work with our vascular surgeons in conjunction with repairing this part. So there are two types of disease that I wanted to focus primarily on today. And there's two different words, and they're related, but they're different problems. The first is aneurysm, and the second is aortic dissection. Now, what is a normal size of the aorta? We can look at men and women, and we know that one size doesn't fit all. So what's normal measurements in a man is not necessarily true for a woman. In the same way, someone who's 6'6" would probably have different measurements than someone who's 5 feet tall. And so when we look at someone, we kind of have to determine what is a normal size for that person. Also, in that single person, the aorta is not the same size the whole way through. And so naturally, it starts bigger at the root and then tapers smaller and smaller as you go through the arch. If you look at this chart here about the normal measurements, you're not going to see any number that starts with a 4. And so in general, what I tell patients is that if your aorta is less than 4 centimeters, you're probably okay. What happens is sometimes people who have a genetic predisposition or people who have high blood pressure, for one reason or another, the thickness or the wall of this aorta can become a little bit weakened. And when that wall is weakened, that aorta can stretch out. And so aortic dilation is the term that we use to refer to that process when the aorta stretches out. And that means that the diameter increases in size. And so you can grow from a normal diameter of 3 to an aneurysm, which is what we consider 5.0 or more. And then just going back, you can see that as the aorta stretches, that wall becomes thinner because you don't make more wall. So it's kind of like blowing up a balloon. The bigger it gets, the thinner that wall becomes, okay? Now, this aneurysm can happen anywhere in the aorta. It can happen in the ascending portion. It could be a root aneurysm. It can affect both. They can also happen in the arch, which is a little bit more complicated to fix. And then they can also happen in the descending aorta, which actually has more treatment options that are not open heart surgery. One of the principles of aortic surgery is that we have to reduce the risk of rupture, and we have to reduce the risk of that stretching before it can rupture. And so what we do is we replace that tube with a synthetic tube to prevent some of the complications that can happen when your aorta is too big. Relatively recently, a couple years ago, we used to have a cutoff of 5.5 centimeters, but now it's lowered to 5.0 centimeters as to when we would consider operation. If you're someone who is already having an open heart surgery, let's say for your aortic valve, if you've been told you have a valve that's too tight or a leaky valve, even at 4.5 centimeters, we would replace that aorta if we were already doing open heart surgery for another reason. Part of these guidelines is that your surgery should be performed at a center where they do a lot of these types of cases, because we can see that the people, patients survive more when the hospital is used to seeing these types of cases and treating these types of problems. And so because people are going to the emergency room and getting CT scans for all other kinds of reasons, we're finding a lot of cases where people had no idea they had aneurysms, and now they're being referred at sizes 4.5, 4.8, 4.9. They're starting to get referred to see a surgeon to begin that conversation. Part of the reason it's important to refer to surgery before you have a problem is because if we do surgery in an elective setting, it's much safer than waiting until the aorta tears or is on the verge of rupture when we do the surgery. And so in an elective setting, if we look at all the cases in the country, the risk of mortality was around 2%. If you show up in the emergency department with a dissection, your risk of mortality is up to 10 times that, up to 20%. One of the caveats to this is that this is considering that your surgery risk decreases when you're at a center that does 20 to 25 cases or more per year. And I'm lucky enough to be at a center where we do over 150 of these cases per year. So we electively repair the aorta because we want to prevent this problem. An aneurysm, I tell patients, it's usually asymptomatic. You don't feel it. You would not know it's there until you know it's there, because you have a major episode. And usually patients know the exact moment that their aorta tore or that they had a problem. And this tearing of the inner lining is what we call the dissection. And why it's a problem, I'll show a couple of pictures later on, is that it allows blood to travel not just within the tube, but along the side of the blood vessel wall. We don't know which people with aneurysms will tear or not. So of all the people out there that have these aortic aneurysms, there's no blood test, there's no predictive scan that we can do to determine who's going to have a problem and who's not. And so this is why we have to come up with these guidelines and these cutoffs of when do we operate and when we don't. So for these patients that progress to dissection, the blood will go through that tear and then it can propagate to other parts of the aorta. And this is kind of, from the very beginning of what I said, the aorta is an organ. It has to be considered in its entirety. And what happens is a focal problem, an aneurysm in one place, can now cause a problem for the whole body because this tear usually propagates. And so when we look at people that come in with dissections, the majority of them affect the entire aorta. And so 60% have what we call a DeBakey type 1 or a Stanford A dissection, which involves the entire aorta. So even though your tear happened up front, it can then propagate all the way to your legs. What that means is that any branch point, any blood vessel off the aorta can have a disruption in the blood flow to that vessel. And so you can see here that inner flap can basically get pushed and block off any branch that comes off of the aorta. This is why dissection is sometimes hard to diagnose, because people will come to the ED and they may have stroke-like symptoms and people think they're having a stroke, but that's just because some of the branches are being blocked off to the brain. Sometimes they have very bad belly pain because their intestines are not getting good blood supply. Sometimes one leg won't move or they can't feel one leg, and that's just because the blood supply gets blocked off. And so again, we have to deal with now this whole body problem. This is a CT scan. This is the only way, or the actual the best way to diagnose these dissections. This won't get caught on a blood test or EKG or an X-ray. This is only picked up by CT scan. And you can see on this CT scan, the first patient there, that flap, that tear. It's supposed to be one circle, but you can see there's a line there where the arrow is pointing. That is where the tear is propagating. That aorta is an aneurysm, so that's a big aorta that's happening in. But if you see the second patient, that's a normal size aorta. So again, you can still have a dissection in a normal size, and we just don't have a way of predicting who's going to do this and who won't. So this is why early detection of these dissections is critical for survival. This was really exemplified by John Ritter, and this was over 20 years ago, but this was the only time that I know of aortic dissection making national news is when he actually presented to the ED from set on a sitcom film set with chest pain, nausea, vomiting, and they actually initially treated him for heart attack. And again, heart attack is much more common than dissection, so that happens a lot, but if you look at the cause of death on his Wikipedia page, it was an aortic dissection. This is another story of a misdiagnosis. This was Jonathan Larson. He actually, wrote the musical Rent, and the day before this came out, presented to a couple different emergency departments. Now, he was quite younger, and so they attributed it to anxiety or nervousness, but he was found, the day before this came out by his roommate, and on autopsy it showed he had had a dissection. But we're here to talk about survivors, so let's talk about the options we have for surgical repair. This is a before and after. So again, the whole idea is to replace this aneurysm before it can cause major problems. This is probably the simplest type of repair we do, where we just replace the ascending. This is a ascending as well as root replacement. And again, that root is where those coronary arteries sit, so we have to actually sew those back into place. It's a little bit more time consuming. There are some options where we can actually save the valve you're born with and just replace the root and the aneurysm around that. And then there are other techniques for replacing part of the arch or the entire arch. And again, these are pretty complex procedures, and we often rely on help from our vascular surgeons as well to do these together. Now, this is a repair that does not require open heart surgery, which is great, but it is stenting the descending aorta, and I think Dr. Manunga will talk a little bit about this later on today. And so let's talk a little bit about the recovery from surgery. You guys probably recognize who this is. This is Arnold Schwarzenegger. He actually was born with a bicuspid aortic valve, which is only common in 1% to 2% of the general population, but he's actually undergone several open heart surgeries to correct that problem. And again, a bicuspid valve is when you're born with 2 leaflets instead of 3. And we know that people that have bicuspid valves also tend to have problems with their aorta because those 2 things are genetically linked. There are different options for replacing the valve. So the one, we have a mechanical valve or a valve made from animal tissue. And then I just briefly wanted to talk about 2 example cases. The first of an aneurysm and the second of a patient with dissection, and this was within the last year. So our first lady actually presented with a 10-centimeter aorta, which is the biggest one I've ever operated on. And this goes to show that not everyone with an aneurysm will have a dissection. But her aneurysm had actually grown so big that it had caused problems because of how much space it took up in her chest. And so this was a picture of her aneurysm. Now, that white part is the aorta, and the heart you can barely see because of how much the aneurysm is pushing the heart out of view. The reason she came to the emergency department was because she was having so much facial swelling because the blood could not drain from her face because there's a vein on the top there that's being so stretched out by this aneurysm that none of the blood could come back from her face to the heart. And so we had to operate to relieve her symptoms, not because she was having a dissection. And so this is a before and after, and you can see how much more space there is in the chest once we remove that aneurysm. You can actually see her lungs on either side in view now. You couldn't see them before. That artery on the top, or that vein, is now no longer compressed, and you can start to see her heart come more into view. And she left the hospital. And so, again, these are examples of when people are referred for surgery, we can actually intervene and save them before they have a major problem. The second case, this gentleman was in his 50s, and this is an example of his CT scan. He had known he had had an aneurysm for a while, and then he had torn, and this tear affects the entire aorta. So his ascending arch and descending aorta is torn. This is an example of the echocardiogram that we did. So this shows that his aortic valve is leaking, but it's leaking because that dissection flap is crossing the valve, and so the valve can't stay closed, and so he actually showed up with heart failure as well. This is what an aortic dissection looks like. The first case was not purple and bruised like this. This is a acute dissection. You can see how thin the aorta and how big it is. This is just a picture from the operating room that we took, a short video, just to give you a sense. This gentleman required basically a replacement of everything, so we replaced his root, the ascending, the arch. Dr. Manunga, who will be speaking later today, was also involved in this case and did what we call a frozen elephant trunk, which is the stenting of the descending. And then he also had to place a stent in his renal artery because he had that blocking of blood flow to the kidney. Let's see. Here's a quick video. So this is the arch replacement. Oh, that's not him. And so this is the after. And so again, this is replacement of that entire arch. And also, he left the hospital as well. Again, this is not him. This is, for patient protection. But a lot of these patients, when we can get them to surgery in a timely fashion, most of them go home. And again, when we replace the aorta in an elective setting, it's much safer than when they show up in an emergency. I did want to mention that this is not just, as a surgeon, I have just one job, but most of what happens to the patient is related to everything else that happens. And so it involves great care from the ICU after surgery, the anesthesiology team, the vascular surgeons, the cardiologists who treat and refer these patients. Up there it says the patient's family. I think that bubble is very important because when we're meeting people, a lot of times the patient is unresponsive or already intubated, and so we really rely on the family a lot to kind of be the surrogate decision maker in these settings. And talking to family members in this kind of emergent setting is never easy, but again, all of these people play such an important role in the success of the patient and having the patient get through surgery and get home. So just in summary, aneurysms are mostly asymptomatic, and you would not feel it had you not, had a CT scan that someone told you had an aneurysm. However, when they do become symptomatic, it's usually a life-threatening emergency, and then time is of the essence in order to save these patients. So elective surgery aims at operating before it's an emergency because, again, the chance of surviving that is much higher than if you were to show up in a state of distress. And this could not be possible without a team approach. Again, I'm very lucky. We have 8 other surgeons and a great team of vascular surgeons and cardiologists at MHI. And again, as a team, we really work to get most of these patients through. In fact, when we looked at our data for survival of these types of operations, we have a much higher success rate than the national average, and I think that's because of the collaborative approach that we take. So again, thank you, and this is just a shot of what I do on a day-to-day basis, but also my family, my 2 children, and my husband. And again, if you have any questions, just feel free to reach out.